Welcome to Learning in 10. Today we will be discussing a systemic review and meta-analysis comparing the effects of misoprostol versus oxytocin in cesarean section. With the increasing incidence of cesarean sections, there is an increasing concern for the complications of cesarean sections, such as postpartum hemorrhage. Postpartum hemorrhage is defined as a blood loss of greater than 500 mL in normal vaginal delivery and greater than 1,000 mL in cesarean section. PPH is a major cause of maternal mortality and is frequently caused by a failure of the uterus to contract adequately, resulting in uterine atony. Other possible causes include genital tract trauma, coagulation disorder, and abnormal placental site. Oxytocin is frequently used as a first-line agent in treating PPH by inducing uterine contractions to reduce blood loss. However, oxytocin can only be given intravenously or intramuscularly, and 10 to 42% of women require additional oxytoxic agents. Oxytocin also causes unwanted side effects such as tachycardia and hypotension, as well as has negative inotropic, antiplatelet, and antidiuretic effects. Oxytocin is also light and heat sensitive and requires cold storage, which may limit its use in resource-poor countries. Ergometrine is an alternative to oxytocin also used in preventing PPH in C-sections. It has similar efficacy as oxytocin and has additional adverse side effects of vomiting, increased blood pressure, and pain after birth. When used in conjunction with oxytocin, there's a small but significant reduction in incidence of PPH. However, the side effects of high blood pressure and vomiting are increased. Furthermore, ergometrine is less heat and light stable than oxytocin, which may make it more difficult to use in resource-poor countries. Another agent used in treatment of PPH is misoprostol, a prostaglandin analog with strong uterotonic activity through selective binding of E-series prostanoid receptors. It is comparatively inexpensive and easier to store, as well as can be administered via different routes. However, side effects include a dose-related increase in rate of shivering and pyrexia. The use and efficacy of misoprostol during C-sections has not been extensively studied to date. Thus, the authors sought to compare the efficacy and safety of misoprostol compared to oxytocin, specifically in reducing blood loss during and after C-sections. Two authors independently searched multiple databases listed here and screened out papers based on the selection criteria. These selection criteria included whether or not the study was a randomized control trial, whether it included cesarean sections, whether it compared efficacy of misoprostol versus oxytocin, whether it had an objective measure of blood loss, and whether the study documented clinical outcomes, such as estimated blood loss and additional oxytocin need. These authors then independently abstracted the data, with a third author adjudicating in cases of discrepancies before conducting statistical analysis. The primary outcomes this meta-analysis looked at were estimated blood loss, change in hemoglobin levels after cesarean section, and necessity for additional oxytoxic therapy, although secondary outcome measures recorded are listed as well. This schematic outlines the review process, wherein 453 citations were screened and evaluated to select 7 articles for final analysis. Between the 7 articles, the studies varied in their routes of administration, anesthesia, duration of measurement, and the outcomes measured. This table summarizes the results of the meta-analysis, specifically in looking at the estimated blood loss. As you can see in the third row, rectal misoprostol was shown to have a statistically significant reduction in blood loss compared to oxytocin. This table summarizes the results of the rest of the meta-analysis, including outcomes such as changes in hemoglobin after cesarean section and requirement for additional oxytoxic therapy. The statistical analysis showed a significant difference in the reduction of blood in the misoprostol subgroup compared to the oxytocin subgroup. Furthermore, it also showed a significant increase of pyrexia and shivering, as well as other adverse effects in the misoprostol groups. No other significant differences were found in other outcomes. Thus, the review and meta-analysis may suggest that misoprostol has several advantages over oxytocin in being cheaper, more easily stored, and having multiple routes of administration. However, there was still no consensus for the optimal dose or route of administration, which may require further studies. Furthermore, the findings that misoprostol is more effective in reducing postpartum blood loss compared to oxytocin is surprising and opposite to the finding of the WHO multi-center randomized trial which in fact found that misoprostol was less effective. Possible explanations include an inherent statistical heterogeneity of effect, which may in fact indicate clinical equivalency of the drugs. Estimation of blood loss was often inaccurate and inconsistent between the studies, which may explain some of the statistical heterogeneity amongst the studies. The sample size was also smaller than the WHO trial. Lastly, the oral misoprostol used in the WHO trial takes longer to reach peak plasma concentration, which may explain the lower efficacy of misoprostol in the trial. In critiquing the review and analysis, we sought to critically evaluate the study's design, characteristics, and findings. The strengths of the paper include its conclusions that misoprostol was an effective alternative to oxytocin in cases of cardiac disease, prolonged labor, and preeclampsia. Furthermore, as a meta-analysis, it is more powerful and precise than any one study. Lastly, no publication bias was detected through multiple tests. However, some of the analysis's weaknesses include poor power, resulting in an inability to make strong recommendations. In addition, most of the papers estimated and did not directly measure blood loss. There was also the possibility that the comparison of oxytocin and misoprostol could be confounded by other factors such as anatomical variation, multiple pregnancies, or surgical technique. Lastly, none of the studies had a control group, which reduces the accuracy of the comparison. Since the analysis was published in January 2013, more research in the same fields have been done. In agreement with the WHO trial, one randomized control trial revealed misoprostol as not being as effective in preventing uterine atony compared to oxytocin. However, multiple studies indicate that misoprostol and oxytocin used in conjunction were more effective than oxytocin alone, or a long-acting oxytocin analog, had equal efficacy and showed better outcomes, suggesting a potential role for misoprostol to be used with oxytocin instead of just as an alternative. In summary, misoprostol is as effective at reducing blood loss during cesarean section as oxytocin, and is a viable alternative when oxytocin is contraindicated. Due to its cost and stability, misoprostol may be a better choice in resource-poor countries. The quality of evidence supporting the findings is moderate. Therefore, larger, double-blind, randomized controlled trials are needed before strong evidence-based recommendations can be formulated. Before we end, here are some last questions to consider that have yet to be answered. Is there an optimal dose or a route of administration for misoprostol? Is there a role for a symptomatic treatment of drug-related adverse events for misoprostol? And can oxytocin and misoprostol be used in conjunction for treatment of postpartum hemorrhage? That concludes this presentation, and thank you for your time.